Good afternoon. Thank you all for joining us for our lunchtime learning presentations. I am Rachel. I work in the wellness department at the hospital. And today we are lucky to have Dr. Jim Little Jr. joining us this afternoon. Dr. Little Jr. is a family physician and medical director at St. John's Family Health and Urgent Care. In 2010, he was instrumental in bringing the POLST program to Wyoming as a pilot project and helped get it passed into state law in 2015. So before Dr. Little speaks to us this afternoon, I'm actually going to introduce Stephanie, who works with the library, and she's going to share a little bit about the resources that the library has available for you all.
Hi, if any of you have been to these before, you know we have the tables set up there. We've just pulled some books in our collection about the topic, and we have some research forms. If anyone would like to do further research on the topic, we can help you with filling those forms out, or just come to the research desk. We've got, you can also make purchase suggestions if you know of other titles that we maybe don't have, but just stop by and see what we've got there on your way out.
So please welcome Dr. Jim Little Jr.
Thanks, Rachel. Can everyone hear me okay? Okay, I'll try and walk around a little bit. Feel free. I only have a few slides, and I'm going to save most of the time to answer questions and have a discussion. Because I think ultimately, a lot of this is about kind of the conversation that we all need to have with ourselves, with our families, with our caregivers, our providers, about kind of what we believe and what our values are. So the goals today, we're going to talk a little bit about the importance of having Advanced Directives and POLST. I'm going to kind of compare and contrast the two so that you understand what they are. We'll go over what the POLST form looks like. There is a handout with a copy of the POLST form that's there for everybody. And we'll talk a little bit about the implementation of the POLST law in the state of Wyoming and how that came to be. Medicine, we always start these talks with the disclosures. I don't have any conflicts of interest. I am a family physician employed by St. John's Medical Center. I'm not an attorney. So if you're looking for legal advice or you need a will, this is not the proper venue. But we're going to talk about how those documents interface a little bit with the healthcare system and how important it is to make sure that again, your family, your caregivers, your providers know what your wishes are. So Advanced Directives have been, for about the past 100 years in the United States, kind of the guidance that we use in terms of what somebody's end-of-life wishes are. And I'm going to talk a little bit in more detail about what Advanced Directives are. But basically, it's a document that is a legal document. It is written by an attorney, and it is intended to express what your wishes are in a situation where you're not able to express your wishes. DPOAHC, a Durable Power of Attorney for Healthcare. We love abbreviations and acronyms in medicine and in law. It seems to be pretty common. And so we'll talk about what a DPOAHC is and how that differs from an Advanced Directive. And then POLST is the new program in Wyoming that I have been involved with. It's a national program, but it just became law in the state of Wyoming last year. And so that's kind of what I want to talk about is how the POLST form can help you and your family through this difficult process. So Advanced Healthcare Directives, most of the time they're written by an attorney, and a lot of times it's a freebie. They give it to you when you have your will done. There may or may not be a discussion about the details of the document. You can download one for free if you want, right off the Wyoming healthcare website. They're written in legalese. They are often 5 or 6 pages long. And it requires some interpretation to be able to understand the content of that document. Most of my attorney friends tell me that they're not in any way qualified to discuss end-of-life healthcare decisions. They may be well-trained and well-versed in teaching you and educating you about what's important in a will, about what's important for your estate, about the legal ramifications of what happens when you die, and pass on your belongings to the people who follow you and your family. But they're not trained as healthcare professionals, and they're not trained to counsel people about the kind of ethics and the values that are important when it comes to making decisions about end-of-life healthcare. The advanced directives usually require the interpretation of courts or judges and attorneys. They may require, often a common clause in an advanced directive is that it requires 2 attending physicians to agree in a situation where someone is pronounced as being brain dead, so that it becomes a very much of a conflict situation when an advanced directive is brought into play. It's pitting often healthcare providers against family members who may have disagreements about what they want. And if you think about some of the big cases that have occurred in advanced directives over the last couple of decades, Terry Schiavo, Carey and Quinlan were some of the names that are kind of important landmark cases that have involved advanced directives, or in those cases, the lack of advanced directives. And so people didn't know, didn't have in writing what those people's wishes were. Advanced directives often live in the wrong place, which is in the safe deposit box at the bank. And that's the last, and most difficult place to access the information. And emergency medical services may or may not be able to honor an advanced directive. It depends on how it's written, and it's usually in the heat of the moment. I can tell you, having been a volunteer firefighter, that it's not the kind of thing that firefighters are trained to do legal interpretation and read. So when it comes time for the ambulance to make a decision about what your wishes are, an advanced directive may not be helpful. And finally, the advanced directives, a lot of the language in advanced directives deals with kind of very infrequent, rare situations. So specifically, what happens if you're in what's called a persistent vegetative state? Well, that situation only applies to, it's less than 0.1% of the population ends up in a situation like that. It's a very uncommon scenario. But that's one of the things that an advanced directive is kind of directed towards, is dealing with some of those less common scenarios. Durable power of attorney for healthcare. This document specifies who your agent is. In the state of Wyoming, it's the person that is your decision maker is referred to as your agent. This can sometimes be included in an advanced directive. So your advanced directive may specify who your agent is, or it can be a separate document. But the purpose of this document is basically who's going to make decisions if you can't make them. And this is a very important thing to have. It's critically important that your agent knows who you are and what you value and what you want them to do in the situation where you can't express your wishes. And it's also, I would encourage people not to name their personal physician or healthcare worker as their agent. There's a conflict of interest there if your healthcare professional is also your power of attorney for healthcare. And it's best if you keep those two roles kind of separated. Medicine has not always done such a good job when we write orders in patients' charts about what their wishes are. Do not resuscitate, or DNR, is a common order that we write. But I think there's a lot of confusion about that. Do not resuscitate doesn't mean don't do anything. And we as healthcare professionals need to be a lot more specific about what your wishes are and how we're going to implement those wishes. So the traditional kind of DNR order or no CPR order is often kind of a confusing thing as well. So what is a POLST? Well, POLST is a national program, and POLST stands for physician or provider order for life-sustaining treatment. And it's a written physician order. It's explicit about what the patient wishes are. It's actionable, and so it contains explicit instructions about what treatments you want and what treatments you don't want. It's portable, so the person who owns the POLST form is the patient. It's not the hospital. It doesn't belong in the safe deposit box. It's intended to be with the patient where the patient lives. It's one page, and I emphasize this whenever I talk to the firefighters and the paramedics. It can even be interpreted by a firefighter and a paramedic. And it's optional. Nobody in here is required to have a POLST form. The state law doesn't mandate that you have a POLST form. But in states where the POLST is recognized by law, which is what we now have in Wyoming, if you have a valid POLST form, then the physicians and providers who are caring for you are required to honor the wishes that you set out on that POLST form. So the older model, the Advanced Directive model, I think was kind of confusing. There were, who was at the center of that model? Was it the attorney who was advising you? Was it the courts who were deciding what could be done if you had a conflict between your family and your healthcare providers? And that is not kind of a modern model for medical care. Really who should be at the center of this conversation is the patient, is you. And surrounding you are your family and your friends and the other close, people who are around you. And really, we as medical providers, me as a physician or your nurse practitioner or PA who is your primary care provider, should be supporting the patient and their family in the decision, because it really is an important kind of patient-centered approach. And there are many, many things that influence our decision-making about kind of death and dying. What are our religious beliefs? What are our morals and values? What are our past experiences with death and dying? Have we seen a loved one who suffered unnecessarily at the end of life? Or did we see a situation where we had a loved one who didn't have an advanced directive and there was conflict at the end because there was a disagreement between family members? Finances affects it. What's the insurance situation? What's hospice care? Does hospice play a role, and how do people sort through that? Medical ethics. What am I as a physician ethically required to do, and how does that interact with the patient's values? So it's kind of this really complex soup of things that influence what our values and our decisions are about death and dying. So the POLST program, basically, when you compare it kind of side by side with an advanced directive, the POLST form is really intended to be current instructions about your wishes, and it's a valid medical order. So if you take that to the hospital and give it to the provider who's on call in the ER, even though they don't know who you are, they haven't seen you before, they haven't had a discussion about advanced directives and what your wishes are, the POLST is designed to communicate in a very clear, simple fashion what you want done in the event something happens to you. They are valid in both hospital and outpatient settings. And that's a little different than a lot of medical orders. Medical orders traditionally are kind of within the four walls of the hospital building. And this is actually valid as an outpatient. So if you do end up with the ambulance being called, the POLST form can be honored by the ambulance crew that comes to treat you. With POLST, you kind of opt in or out of specific things, and I'm going to go through the form so you can kind of see what the choices are. The advanced directives, like I said, are often more esoteric. They're talking about situations which may or may not occur, and so it's kind of guiding future treatment. The advanced directives are really appropriate for all adults. Every adult should have an advanced directive. If you're over 18 years of age, it's appropriate to have one. But POLST is more intended for people who are, within the last, year or 18 months of life. Now, I left my crystal ball at the office, so I can't tell for sure when that's going to be. But I think it's important that people understand you can have a POLST anytime. There's nothing wrong with having a POLST when you're 18 if you want to have one. But really the purpose is to kind of guide that end-of-life decision-making. And they're not mutually exclusive. Both documents play a role. In a situation where there is a conflict or there is a disagreement between physicians and your agent about what to do, the POLST will guide them in terms of how to resolve that conflict. So you still want an advanced directive even if you decide to complete a POLST form. So the POLST program started in Oregon, where I did my medical residency in family medicine. And it started as a collaboration, and it was a collaboration between physicians, between patients, and medical ethicists, religious leaders. There was kind of a large coalition of people that got together and said, how can we improve what we're doing now and make it better? When I moved back to Wyoming, about 7 or 8 years ago, there was no program here in Wyoming for POLST. So we started a small pilot project in Teton County to see whether we could potentially bring the program back to this, to the state of Wyoming. And through several kind of bumps in the road, we managed to get it introduced into the legislature. First in 2013, when it went down soundly, actually got withdrawn by the legislator who introduced it for us because there was some kind of miscommunication and we hadn't done the necessary footwork to get the program into place. And I learned a lot from that. And a few years later, we had it introduced into the legislature last year, 2015, by Representative Sue Wilson out of Cheyenne, who's a fantastic state legislator, if anybody knows her. And it was passed in 2015, became law in 2016. Do you have a question?
The 3 shades. What were the 3 shades of the states?
Oh, the 3 shades on the map. So the dark colors are the programs that are kind of fully implemented or endorsed. So the 2 dark shades of pink are the states that have laws or have officially recognized the program. The lighter shades of pink are in some kind of stage of implementation along the way. And the ones that are white, which look like they're light pink up there, are the only states that haven't implemented POLST form in some way. So when we started the program as a pilot project here, there were about 23 states that had implemented it in some way, and now you can see, I think there are only 2 or 3 states that haven't implemented the POLST program. So it became the law of the state of Wyoming January 1st of 2016. So I want to just kind of take you through the form and explain what the form is, because the form is kind of the tool that we have at our disposal, but really the important thing about the POLST program, it's about the discussion. That's the important part. And so I want to emphasize that now, excuse me, and I'm going to emphasize that again in a few minutes, that really it's about the conversation. And the paperwork is just the tool that we use to help make sure that your wishes are honored in the event something happens. So you'll notice right at the top it says, first follow these orders and then contact the physician or nurse practitioner or PA. This is intended to be the guiding document. With an advanced directive, I don't know how many attorneys take call at 3 in the morning when their patients have a medical crisis and they need a emergency interpretation of the advanced directive. But this is really intended to be the guiding document, and it should be the thing that people use as that tool. CPR, which is cardiopulmonary resuscitation. If you watch TV at all, seems like it's 100% effective. Everybody survives. They usually jump right up. And, woo. But that's not reality. And I think, most people know that. Most people know that, when your heart is stopped and your breathing is stopped, we have tools that we can use to attempt to resuscitate you. But, it's not 100%. It's not even 20%. The statistics for out-of-hospital successful cardiopulmonary resuscitation are somewhere well below 10% success rate. And depending on your underlying medical problems, if you have a terminal life-threatening illness, advanced heart failure, advanced emphysema, those success rates drop below 1%. So I think this is kind of the crux of the conversation, is having the discussion with your provider who knows you and knows your medical problems about, do you want CPR? Is that really what you value? And some people say yes. Some people, even if they have a terminal cancer, they say, I want everything done until there's nothing left to do. And that's totally okay with me as a provider. But I think the important thing is again, getting back to that discussion. So CPR, or do not resuscitate, which is sometimes also referred to as allow natural death in some states. So if you do have a pulse and you are breathing, then the other medical interventions comes into play. And you have a choice here of basically full treatment. You would want everything. If you needed to be on life support temporarily, you would want to be on life support. So if you needed a surgery and had to have a breathing tube put in and be on a ventilator, you would want that. It includes being in the intensive care unit. If you need to be transferred to intensive care and have kind of full intervention, then you can indicate that that is what your wish is. Selective treatment is kind of a step below, and essentially what we're saying with selective treatments is that you would want things like IV fluids or medications or kind of non-invasive things like oxygen therapy to help you with your breathing. And even if you needed it, you could have, there's a device called CPAP or BiPAP, which is a machine that helps with your breathing but doesn't require us to put a breathing tube into your lungs. And with people who are on selective treatment, we're basically saying we're going to try not to do things that are too invasive, too painful, too high risk. We're going to kind of selectively choose for that person what fits the situation. The goal here is to avoid intensive care. We're trying not to put you in an ICU. Intensive care units are a fantastic thing if you have an acute medical crisis and need to be in them temporarily. They can be a very, very frightening place and a very, very uncomfortable place for someone with a terminal illness to die, and for the family members of a person who has a terminal illness to kind of see the last days of the person that they love. So intensive care is a useful tool, but it's not appropriate for everybody. And then finally, comfort-focused therapy. Comfort care has a long tradition in the United States. The hospice program, we have a fantastic home hospice program here that's underutilized, to be honest with you. We should use it more. The average duration of a hospice admission in the United States is less than 48 hours. That's too late. And if there's one thing I can do to change kind of our philosophy about how to help people who are going through the death and dying process, it's we need to involve hospice earlier. We need people to benefit from the services that hospice can provide. So comfort-focused therapy is that we're going to use medications. We'll use things like morphine or medicines to help with anxiety. We'll use oxygen. We'll use suctioning if we need to kind of help clear out secretions in your throat. And those types of things that are all comfort care measures to to provide comfort to the patient. With comfort measures, our goal is not to transfer the patient to the hospital, but there are situations where it's still appropriate. Again, it gets back to that kind of do not resuscitate. Doesn't mean don't do anything. Even if you don't want CPR, if you're on comfort measures and you break your hip, for example, it may be that the only place that can provide adequate pain relief is for you to go to the hospital temporarily. And that doesn't mean that we're going to take you to surgery and fix your hip, because that would be inflicting more pain, but it may mean that we need to be able to provide 24-hour nursing care and more intensive services in order to make you comfortable. Artificially administered nutrition, long-term feeding tubes or no long-term feeding tubes is kind of the ultimate decision making. These feeding tubes were really the issues with the Terry Schiavo case and the Karen Quinlan case and some of these other cases that have kind of, brought a lot of attention to kind of end-of-life decision making. Because, in all those cases, the people were essentially brain dead or in what's called a persistent vegetative state. And the question was whether to continue to feed them or not. And that was the difficult decision for all of those families and ultimately the legal system to make. But this is really the kind of most important part of the form. And that is kind of what your goals for your medical condition are. And I want to point out that on the old version of the form which we distributed, it's a pretty small box. We don't have a lot of room to write in there. But the newer version of the form, we've expanded that because it really is the most important thing. And that's, what do you want? What's your goal? What's your value? And it's really, really important to understand that this is about the conversation. And the conversation gets back to that kind of patient-centered model of the patient and the family and close friends and the physician. And those are the people that really need to be in the room and have that discussion. Signatures, it's a legal document, so we have to have signatures on it. So the status of the POLST law, it was passed in 2015. Governor Meade signed the bill, and it did become the law on January 1st of this year. The process for this to be implemented, though, requires that they write the rules and regulations which guide how it's used, as well as approve the final version of the form. So that's in public comment stage right now, and we anticipate that we'll have the final version of that here March or April, really literally any day now, should be coming. There is a website called the POLST website from the Wyoming Medical Society, and there's copies of the form on there that you can download. There are a couple of videos that have some additional information about the program. And I want to kind of point out a couple of books that I think are very inspiring and helpful, useful books for people who are interested in reading more about this topic. The first one is When Breath Becomes Air. I just finished this book. It's a fantastic book by a gentleman who's a neurosurgeon, a very, very talented and skilled neurosurgeon. And he developed lung cancer during his neurosurgery residency training and passed away from lung cancer. Atul Gawande is one of the most important medical writers of our generation. Atul is a surgeon, and he writes extensively on quality in medical care and what we can do about quality. And his book about being oral and end-of-life care is a very important one. And then Oliver Sacks is also a kind of a legend as a physician, and talks a lot about his diagnosis and ultimate death last year, and the things that he was grateful for. So I'd encourage you to look for all three. I think all three of those books are in the library here. I'm not positive about that. So I want to just finish with this quote from Atul Gawande because I think it really resonated with me. And he says, "We've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it's larger than that. It is to enable well-being, and well-being is about the reasons one wishes to be alive. Those reasons matter not just at the end of life or when debility comes, but all along the way." So just to summarize, Advanced Directives, Power of Attorney for Healthcare, POLST are all important parts of making sure that your wishes are honored at the end of life. And it's critically important that you have the conversation with your family, your agent, your power of attorney, and with your physician. And that really should be, a couple of years ago, one of the things that derailed the initial version of the Wyoming POLST law was there was confusion about whether the POLST program was intended to be physician-assisted suicide, and the kind of Right for Life organizations in the state had incorrect information about it. But the consequence was that it was kind of right on the heels of the national election where death panels had been a popular phrase or terminology. And so we got derailed with a program which was really intended to be about honoring patients' wishes because people thought that it was going to be the government deciding what to do for them. And that's really not the case. I want to make sure everybody understands. The people you want to have this conversation with are your family and your providers. And the government doesn't really play into it in any way other than providing a tool, which is the POLST form that we can use. So that's all I have for you. I'm basically wanted to make sure I left enough time to answer questions. I do want to finish with a photograph of one of the things that I live for. This is a total solar eclipse. I took this picture last March in Svalbard, which is an island located basically north of Iceland. It's the furthest northern point you can go before you get to the North Pole. And we're lucky enough that in August of 2017, you get to see one right here in Jackson Hole. It's the only time in over 400 years that there's been a total solar eclipse here. But this is one of the things that's kind of the most inspiring natural phenomenon that I've ever seen. And I've been lucky enough to see about 8 of them now, I think, 7 or 8 of them. My father is up to a dozen, I think. 9? Okay. Working on a dozen. Hoping to see the next ones, right? But that's all I have, and so I'll take questions at this point. Go ahead.
I'm picturing the ambulance crew coming. How are they going to know that I have a pulse? Will I have a little yellow card in my wallet?
So there are a couple issues with that. One is that several of the states that have implemented the POLST program have what's called a registry. So when you complete the form, it gets scanned or faxed into the statewide registry, and then it's available to any licensed physician or provider or to any ambulance crew that comes. At this point, we don't have that in Wyoming, but that's probably a future direction that the law will go, is to decide whether or not to have a statewide registry. When the POLST program comes out, there's also discussion about having a wristband. Some people may remember the Comfort One program, which was kind of a intermediate step that was part of Wyoming law and actually still is. If you have a Comfort One form, it's still a valid form. And there is a wristband associated with that. But the important, the form itself stays with the patient. And so in Oregon, where I practiced before, people would have an envelope either right inside their front door or on their refrigerator if they were at home. and the POLST form would go into that envelope and be in a place where the firefighters and medics knew to look for it. Here, you're basically going to have to be in a place where someone knows that you have the form and can give it to the ambulance crew when they show up.
But what if you're not at home? What if you're in an auto accident?
Right.
Is that form on the refrigerator no better than in your safe deposit box?
It's a great question, and that is, what happens if you get in a car accident and you don't carry your form with you? I wouldn't carry my form with me. And so the answer to that is that your provider, your physician who has to sign the form with you, has a copy of the form. And when I sign a copy of the form with a patient, I always fax it to St. John's Hospital so that it becomes, it's in the electronic medical record at St. John's Hospital. So if you show up in the ambulance to the emergency room and they pull up your chart at the St. John's emergency room, then a copy of your POLST form is immediately available.
You have to be lucky to have your accident right here.
Usually, yeah, it's a challenging problem, and that's why many of the states that have kind of are the dark pink color on there have gone to the statewide registry of the forms. The problem becomes even more challenging when you talk about people who are traveling. We have, I can't tell you how many people I see every year that are on their bucket list trip to Yellowstone. And they show up in my office because, you know, they have a terminal illness and they wanted to see Yellowstone before they died. And many of those people bring their POLST form with them. And one of the things that the POLST law ensured is that there is reciprocity for other states. So if a patient shows up here from Washington State with a POLST form and brings it into the emergency room in Wyoming, then there is a process in the law that basically specifies that the form can still be honored even though it's not a Wyoming form. Go ahead.
I think one of the most compelling points out of the POLST or an Advanced Directive is that when you do come to the end of life and you're there in the ICU unconscious, it's left the family that's surrounding you to make those difficult decisions. And if they don't know what your wishes are, or they're grappling with their own ideas of what they would do on their own instead of what you want to be done, it's just such a relief for those family members to just be able to spend those minutes reading with their loved ones instead of making very, very difficult situations.
Yeah, absolutely. I think that, you know, as a child, none of us want to be in a situation where we have to decide, you know, for our parent what our parents want. And if you never had that conversation with your parent, then, you know, it's a very, very difficult situation for family members to be in. And, you know, we all hope that we're going to live a kind of rich and fulfilling life, and we'll get to the end of our life, and, you know, one day we'll go to bed and we won't wake up, and we'll have a peaceful you know, death with no conflict involved. And unfortunately, that isn't always the case. And so the more we can do to kind of give our family members and our loved ones the tools to help them with the decision making, the better off we are, without a doubt. And even if you don't have an advanced directive or a POLST form or a power of attorney for healthcare, you still need to have that conversation with your loved ones. You still need to tell people what it is that you value. Go ahead.
All of these three forms, can family members override them?
That's an excellent question. So the question was, with all three of these forms, can family members override them? I'm going to start with the POLST form, because when the law was passed in Wyoming, one of the senators inserted a clause
that the final version of the POLST form, which should be out next month, has an additional line that I didn't show you. And that additional line basically says, if I initial this line, my family members cannot change my decisions if I am incapacitated. And it was because that senator had the experience where an advanced directive had been signed and was in place, and the family member who was dying had indicated, what their wishes were, and the children reversed the decision on the advanced directive because they were the powers of attorney for that patient. So the POLST form in Wyoming is unique in that regard. I'm not aware of any other state that has implemented that particular clause, but it's an important clause, for people to be able to express what their wishes are and make it kind of irrevocable, if you will. Go ahead.
So in that D section of patient goals, if you're in a state that's not going to have that clause, would the patient be able to write down in patient goals, this is my wish and no one can revoke it, or?
The portability is somewhat challenging. I think the clauses that are really kind of clear are what your wishes are regarding CPR, whether or not you want CPR, what other treatments you would want, and the tube feeding clauses. And those are the clauses that have all been kind of tried and proven through the legal process and through medical research to be kind of the important questions and processes. But it does become difficult when you have, state-based programs and people are moving from state to state. Again, what you hope is that the people who are your agents or decision makers and your providers are going to be there and involved at the time that something happens to you. I can't think of a scenario where you're going to have, every possible contingency addressed through the form.
And with that, if you have no family within 3 flights of you,
Yep.
or I'm thinking about my older parents, 82, they've got directives, but I don't know in New Hampshire if they have this POLST yet.
New Hampshire does have a POLST program, I believe.
Okay, where can I also in this patient goals say, if in Part B, I say full or selective comfort, can I note and say, but wait 20 hours until one of my family members is there with me? And
Yeah, that's the discussion that I have with my patients. It's okay, what happens, if one of your children, gets scared at the end, which is what happens, and changes their mind. What do you want? And I write that into the box. So I think those things that kind of are important to you is what belongs in that kind of last box of what your goals are. Because those are unique to you. Those are different for every person. Some people, religious faith plays a very important role in people's decision about this. And so some people, really want last rites to be read before efforts are halted. And if that's important, then write that in to the box, because that's something that that we can arrange. I mean, the hospital, we have a spiritual caregiver on call 24 hours a day for just that purpose, so that if there is a situation like that, we can provide that.
Are physicians already trained to help patients fill these out, and are they knowledgeable about the narrow little box and what really needs to go in there and those kinds of things?
So that's a great question, and that is, are physicians trained? And we are in the process of kind of rolling this out statewide. it depends right now a lot on where a physician trained and whether there was a POLST program in that state. And it also depends a lot on, when you were trained. Because if you're a physician who's trained in the last decade, then you're probably familiar with this form, or not, if not with this exact form, with very similar forms. Physicians who are trained 40 or 50 years ago, that's not necessarily the case. It wasn't really a core part of residency training programs. And it depends also what the specialty of the physician is. Physicians who do things like family medicine, internal medicine, kind of the primary care specialties, or are oncologists where they deal with a lot of kind of death and dying issues, are much more likely to be trained and familiar with programs like this than physicians who are in other specialties.
Dr. Little, can I just add something there? We're actually super fortunate to have David Peterson here, who is trained in all of these matters, and he's going to be doing a special presentation kind of discussion group at the Senior Center on Tuesday, March 8th, where he will actually be assisting people in filling out advanced care directives. So if you're interested, that is open to everyone of all ages. We'd love to have you join us. And we also will have members of the religious community there to answer any other questions you may have.
Go ahead.
What should one expect as defaults in the case of not having these forms?
So if you don't have an advanced directive, or you don't have any sort of a POLST form, kind of what are the defaults? Well, the assumption is that you would want full treatment. So if you have a cardiac arrest and you don't have a medic ID alert, bracelet or necklace or a wristband that says what your wishes are, the assumption is you would want full treatment. Maximum everything. In Wyoming, and in all states, there, in terms of who your agent is, if you haven't specified one, the default decision maker is your spouse. If you don't have a spouse or your spouse is not available, it goes to your children. And after that, you have to ask an attorney, because I don't know. We've got some attorneys in the audience. Do you know who the next default decision maker after that is?
I would suppose it goes down the line.
Next to the kin.
Yes,
Yeah.
exactly, but I don't know that.
But the Wyoming law is specific that it's spouse first, followed by children. So there was another. Go ahead.
What time is the senior center presentation?
It's at 12:30 p.m., so right after lunch on Tuesday, March 8th.
Yes.
This isn't really a question as much as a statement. Having been through, death and dying with a loved one fairly recently, I can't tell you enough how important it is to have that conversation with your loved ones before the stress of the illness becomes sort of, takes all of your energy. You find that it's a scary conversation to initiate, but then you realize that everybody in this room has probably had some thoughts about what they would want. And it's pretty easy to articulate those thoughts when you start talking about it. It's easier than you might think. So it's just a good conversation.
And I think as the child, it's my wife Carol, so thank you. As the child of having lived through parents or grandparents dying, I think it's very important that you don't assume you know the answers.
Right.
Because each person's journey is different, and the decision that they make about what they want will change with time. So for me, at the ripe old age of 47, I will make a very different decision than I would make if I was 87. And as children, I think the natural assumption is that mom and dad would want everything. That's not always the case. And you really do need to talk it over and have that conversation. And don't make assumptions either. My mother-in-law was a devout Catholic, and I made assumptions based on her religious faith about what she would want as, you know, her end-of-life care, and I was wrong about what, you know, she ultimately decided she wanted. So I think having that conversation again gets back to the conversation and the discussion, and it's a difficult one, but it's so important to have that.
Well, I think that goes to the fact that these things are changeable, mutable, and that they should be reviewed periodically, because if you develop cancer, that may be a whole different story than where you're at 47. It's not a done deal until the lid closes. So you can make those choices as long as you're conscious. And I'd like to know also the 5 wishes. What does that have to do with any of this?
So the 5 Wishes program is another voluntary program that is basically kind of a values-based or program to allow you to express what your wishes are for end-of-life care. And it's a useful tool. It's, again, it's not kind of endorsed by state law, so it's not portable, and there's no kind of mandate to honor that. So it gets confusing, because we do have Comfort One and 5 Wishes and, you know, all these multiple programs. And that's kind of the intent with the POLST program, was to hopefully clarify some of that and to bring the conversation back to where it belongs, which is the patient and the provider, and to make it enforceable, to make it something that would be honored regardless.
I have a chip implanted in my dog. Can I have a chip with my pulse implanted on me? And if so, will it be read by the ambulance or the emergency room that takes me out? I'm back in the mountain range, hiking, and somehow they get me out. They fly me out or whatever, you drop down and pick me up in your plane. Are you going to have a monitor or something that'll read my chip?
I love that idea. It may be a little difficult to implement. The similar version of this talk that I give to healthcare professionals, I have a slide that I took out of this talk, but there are people, many of them doctors, who have tattoos on their chest that says no CPR or no defibrillation, because in order to do CPR, you got to expose the chest, and if you want to absolutely be clear with what you're doing, you know, if it's tattooed right there, I don't think there will be a lot of argument at the time. But it's a very valid point, and that is that, you know, we do need to be able to clearly identify what people's wishes are, clearly communicate and honor those wishes, and that's what it's really all about. I think we maybe have time for 1 or 2 more. Go ahead.
If the patient is already beyond the point of having the conversation, but the conversation was had a while ago, and now the POLST form is available, can the durable power of attorney person sign the POLST form?
Yes, excellent question, and that is, for example, if someone has dementia, and it's advanced dementia, and they are no longer able to make their own decision, is it possible for the power of attorney or the next of kin to sign the form? Absolutely. Whoever the person is who is the decision maker or the agent becomes the person who can sign the form. Go ahead.
Quick question. If we go to our providers, will insurance or Medicare cover end-of-life counseling?
Very good question. Yeah, this is a great the question was, if we go to our providers, will Medicare cover discussion and counseling about end-of-life decision-making? And the answer is, kind of. Medicare actually passed what are called CPT codes, which are the codes that guide billing, to allow providers to bill for this service. But unfortunately, Medicare isn't one thing. Medicare is a regional thing. And in our region, the codes that they use for end-of-life care at this point, I don't believe are being reimbursed yet. Now it's a process that usually just takes a few months for it to kind of percolate through the system. So the answer is yes, it is covered, it will be covered eventually. I don't believe that today it's covered, but I see it as core to what I do. And so if it's the conversation that needs to happen, I have the conversation, and I honestly don't really care if Medicare pays for it. I shouldn't say that. They'd probably consider that fraud. Is Dr. Hoheiser here?
You care if the patient pays for it, Medicare doesn't?
No. These are getting into complex billing issues. If you're a Medicare patient, we can't bill separately for things that Medicare won't pay for. It's not, basically Medicare decides what they pay for. So we don't, there's a process you could pay for something outside of it, but it's just part of routine office visits as far as I'm concerned. It's a part of every conversation I have with patients at their annual exam. When I see patients who are, generally over the age of 50 or 60, then I'm going to have a conversation as part of that exam about what your wishes are. Well, thank you all. I really appreciate your time.